So hello again, our dear friends. We have been asked to show some focused video about the ACC 2023 guidelines of the chronic coronary disease, which is usually not showing a big difference from the European Society of Cardiology updates for chronic coronary syndromes. But our friends wanted us to give a short video about this update. So let's see here what's different and what's new in the American College of Cardiology 2023 guidelines. So this is the 2023 guidelines by the ACC-AHA, and it has been done in collaboration with several societies, including the SCI, Society for Cardiovascular Angiography and Interventions. So the guidelines previously, the last update was 2014, they used the term stable ischemic heart disease or SIHD. They changed this term to chronic coronary disease. This is similar to what happened with the European Society of Cardiology guidelines when they changed the term of chronic stable angina to chronic coronary syndromes or CCS. So the American acknowledged the term of CCD, chronic coronary disease. Europeans acknowledged the term of CCS, chronic coronary syndromes. Why? Why the European Society of Cardiology, followed by the American College of Cardiology, both of them shifted towards the term disease or syndrome? It shows that this is a chronic illness that needs more than one specialty. Sometimes the interventional cardiologist is involved. The general treating cardiologist is always informed and involved. Sometimes you need the nurse, sometimes you need the geriatrics, sometimes you need the dietitian, sometimes you need another specialty to be involved. Definitely cardiac rehabilitation is there. And you need to explain to the patient that the condition is not solved by a single tablet or a single stent inserted in a procedure, because you need to control a lot of other factors. You need to control your lipid profile, you need to follow up in the lipidology clinic, you need to do some cardiac rehabilitation, you need to do some exercise, you need to quit smoking, you might need a social therapist to work with you, and so on and so forth. So it's a chronic form of disease that uses multiple specialties in the treatment strategy. The nice thing is that they posted the JACC tool, and this is an interactive tool which involves some questions, and you fill those questions online. It's actually a free tool. You just go online, you write the JACC CCD guideline interactive tool, and you will get this page. Once you get this page, you have just the questions to answer by ticking yes or no. Does the patient have angina as a presenting complaint? Did he have MI within the past 1 year? Is he having type 2 diabetes? Is there a history of heart failure with reduced ejection fraction? What is the current LV ejection fraction? Mid-range, reduced, or preserved? Did you achieve an LDL cholesterol of less than 70? Is the patient hypertensive? Is the patient on maximally tolerated statins? And is the patient on beta blocker? So we have a virtual patient complaining from chest pain. He didn't have MI in the past 1 year. He is diabetic. He doesn't have a history of heart failure with reduced ejection fraction. His ejection fraction is preserved more than 50%. His LDL cholesterol did not reach the target. He is hypertensive, on maximally tolerated statins, and on a beta blocker. And then we press submit. So when we press submit, we get the guideline recommendations for this patient plan. You get a screen like this. Class 1 indication for SGLT2 inhibitor or GLP-1. Class 1 indication for a blood pressure target of less than 130/80. Class 1 indication for anti-anginal therapy, beta blocker, CCB, long-acting nitrates, additional of a second anti-anginal agent. Ranolazine recommended, sublingual nitroglycerin for short-term relief of angina. Ivabradine might be harmful. ACE inhibitors or ARBs for control of hypertension and morbidity and mortality. High-intensity statins is recommended. And if he's not controlled on the high intensity statins, you put the PCSK9 monoclonal antibody. Colchicine for secondary prevention might be considered as a class 2B. And of course, the use of non-prescription or dietary supplements are not beneficial. So you get all the recommendations for this patient as per the guidelines as the result by a simple mouse click. So the first thing was the application or the interactive tool. This you have now, we explained it to you. And now let's see what are the top 10 take-home messages from the ACC 2023 guidelines. Number one is what we said. We use the term chronic coronary disease, so we are emphasizing on a team-based, patient-centered care that consider the social determinants of health along with the costs shared in the decision-making for the risk assessment, testing, and treatment. So number one is what? Number one is a team approach to the patient. Team approach to the patient. As you see, you have the patient, you ask about his symptoms, his quality of life, you assess his cardiovascular risk, you offer him the treatment options, and you ask him about his preferences, and you have a discussion with him. Involved in this big circuit, you include the social support, you include the dietitian, you include the exercise, you include the rehabilitation, you include the nutrition, and you include all the needed specialties. All of those are involved with you, focusing on the cardiac rehab, focusing on the dietitian, focusing on the behavioral health and social work, especially for smoking cessation. Number two, you need to take some time to explain to the patient or the dietitian explaining to the patient that the non-pharmacological therapies, including the healthy dietary habits, as well as exercise, are recommended as a class 1 recommendation for all the patients with chronic coronary disease. And this is a nice slide that shows the patient to choose from what, to avoid what, and replace what. So you choose the vegetables, the fruits, the legumes, the nuts, the whole grains, the lean protein, the complex carbs, the dietary fibers, the monounsaturated fats to be less than 20% like olive oil, the polyunsaturated fats to be less than 10% like salmon. Instead of the saturated fats, reducing the dietary sodium, processed meat, refined carbs, sugar sweeteners, alcoholic beverages, and of course avoiding the trans fats and the fried foods. You tell the patient not to avoid physical activity. Physical activity is recommended. Physical activity is advocated. So the first thing, we had a team approach. The second thing, we spoke about the diet. The third thing, we're encouraging the physical activity, including activities to reduce the sitting time, increase aerobic and resistance exercises, cardiac rehabilitation for the patient, and telling the patient and educating the patient that this provides significant cardiovascular benefits, including decreased morbidity and mortality. And this is a nice slide. Instead of watching a TV, you should walk your dog. Instead of taking the escalator or the elevator, you can use the stairs. Instead of sitting with a friend in a coffee shop and using the laptop and the screen time, you can move and walk and meet and have the discussion while walking. 10% reduction in mortality, cardiovascular disease with every 1,000 increase in the daily step. So this is very good. If you increase your daily step count by 1,000, you'll get a 10% reduction in mortality and cardiovascular disease. So this is a very nice slide as well. Let's dig into the pharmacotherapy. So the pharmacotherapy, we have two main updates. One of them, of course, is due to the game changer, the SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors, and the GLP-1 agonist, which are recommended for patients, cardiac patients, heart failure patients with coronary disease, including groups without diabetes for SGLT2. And we get a new recommendation also for the beta blockers. Previously, we used to say that beta blocker in ischemic heart disease is like a green card, you use it for all the patient. But now we focus, where is the indication? The indication, if the heart failure, of course, is impaired, it's by the heart failure guidelines. and for control of angina, of course, with calcium channel blockers. Both of them are first-line anti-anginal therapy. But what's new is that the long-term beta blocker is not recommended to improve outcomes, the mortality benefit, in patients with chronic coronary disease who did not have a myocardial infarction in the past 1 year, or with a left ventricular ejection fraction, which is not impaired. And here, I will show you in the next two tables. The first one is the update between the 2014 ACC guidelines and the 2023. In the SGLT2 side, we did not have those medications available in the guidelines at that time. But in the 2023, you can see green is class 1, that in patients with chronic coronary disease who have type 2 diabetes, the use of an SGLT2 or a GLP-1 agonist, of course, has been proven to show a cardiovascular benefit, reducing the risk of MACE. And this is for the two molecules. In patients with chronic coronary disease and heart failure, ejection fraction less than 40, of course, SGLT2 is class 1 for morbidity and mortality, improving symptoms and improving quality of life, whether the patient is diabetic or not. Okay, so if the patient is ejection fraction more than 40%, it's a class 2A still to use SGLT2, decreasing heart failure, hospitalization, and improving quality of life, whether the patient is diabetic or not. So here we have the new recommendation compared to the previous ACC guidelines regarding the SGLT2 and regarding the GLP-1 agonist. Okay, so for beta blockers, the previous guidelines was a green card, started and continued for 3 years with normal function after MI or ACS, and of course for those with heart failure. And for those with heart failure, we have the 3 molecules that have been studied, the carvedilol, the metoprolol succinate, and the bisoprolol. Okay. So in the 2023 guidelines, now we have a little bit twist in the update. Okay, in patients with chronic coronary disease and LV ejection fraction less than 40, with or without previous MI, this is a heart failure guidelines. This is a class of recommendation 1. Okay, let's see the second one. In the patient with chronic coronary disease who were initiated on beta blocker for previous MI, without a history of LV ejection fraction less than 50, angina, arrhythmias, or uncontrolled hypertension, reassess the indication after 1 year because you might stop it. The beta blocker therapy here is a class 2B beyond 1 year. It's still green for patients with ejection fraction less than 50 to use the 3 molecules that we described, the metoprolol, the carvedilol, the bisoprolol, with titration, of course, and preferable to other beta blockers. And you get by red, which means a class 3, but class 3 of no benefit, in patients without a previous MI, without an LV ejection fraction less than 50, it's not beneficial in reducing the MACE, but it's still the first medication with calcium channel blocker to control angina if your patient has symptomatic angina. So actually still beta blockers are having the role, whether regarding mortality or regarding control of angina. And here this table shows the comparison between the ACC guidelines and the European Society of Cardiology guidelines. As you see here, the SGLT2 and the ESC are receiving green, class of recommendation 1, whether the patient is diabetic, of course, or the patient is impaired ejection fraction, whether diabetic or not. In the ACC guidelines we previously showed, they also talked about the GLP-1 in the patient that are diabetic, and for ejection fraction less than 40, if the patient is diabetic or not, to use the SGLT2 at a class 1. If the ejection fraction is more than 40, you get the benefit from the heart failure hospitalization and the quality of life. For the beta blocker, it's still green in the European Society of Cardiology guidelines, even class 2A for the past STEMI, previous STEMI, regardless the time, 1 year, 3 years, they did not focus on the time in the European Society of Cardiology guideline, but in the ACC, as we previously discussed, the timing is important, less than 1 year or beyond 1 year, and the ejection fraction is important, less than 50% or more than 50%, but less than 40%. Number 6, the recommendation regarding the statins, regarding the lipid control strategy. So actually, the lipid control strategy, you get the lower targets. If you achieve the lower targets, the first line is statins for lipid-lowering patients. The adjunctive therapy like the PCSK9 are used in selected population, and after using the statins at first, of course, the long-term outcomes of inclisiran is not yet available. Okay, the seventh recommendation is the shorter durations of depth in certain circumstances, like patient at high bleeding risk, patient is going to non-cardiac surgery, and the famous 1, 3, 6, 12 months chart, whether the patient has concomitant indication for oral anticoagulation, like atrial fibrillation, for example, or without concomitant indication, like the patient does not have an AF. Of course, if the patient has a mechanical valve, you're going to use warfarin or vitamin K antagonist, I mean. But if the patient is not using a mechanical valve, like atrial fibrillation, and he has an indication for a direct oral anticoagulant, previously also known as NOAC or novel oral anticoagulant, but they're not novel anymore, so we use the term direct oral anticoagulant. If the patient has chronic coronary syndrome or chronic coronary disease, and he did not do a PCI, he did not put a stent, he will use, of course, aspirin for 12 months. If he had a previous ACS within the past 1 year, then he will use the dual antiplatelet therapy, and after that, he can extend up to 3 years and then continue on aspirin only. If the patient did a PCI and he does not have a high bleeding risk, he will use the dual antiplatelet therapy for the stent at least for 6 months, and then he can continue by a single antiplatelet therapy beyond 1 year up to 3 years. If he has a high bleeding risk, you use a shorter duration for the depth, 1 month or 2 months or 3 months according to the patient assessment, and after 3 months, you can drop out the aspirin, you continue with the P2Y12 inhibitor until you complete the 1 year, and if you want to go to the extended strategy up to 3 years, you use the single antiplatelet. If the patient is using an oral anticoagulant, like a direct oral anticoagulant, rivaroxaban, apixaban, edoxaban, whatsoever, if he's using this therapy, then you will need to give a triple therapy if the patient did a PCI. You will need an aspirin, you will need a clopidogrel, and you will need your DOAC. In this case, if the patient has a low bleeding risk, you can put them together for up to 1 month. If the patient has a high bleeding risk, you can drop out the aspirin after 1 month. And then continue with the oral anticoagulant, the DOAC, and the clopidogrel. After 6 months, you can drop out the clopidogrel and continue with the DOAC alone. If the patient did not do a PCI, you can just give DOAC and you don't need to give aspirin or clopidogrel if the patient has a high bleeding risk. Number 8, the dietary supplements, including those with omega-3, the fish oil, so on, are not recommended unless you are using the highly purified form, which is stated in the guidelines. So using the fish oil, using the dietary supplements, using the so on, the so forth, is not recommended because all the trials were not showing a mortality benefit in those patients. Okay, some patients are worried and anxious. Some cardiologists are also worried and anxious, and usually they form, okay, let's do an exercise test every 6 months. Let's do a radionuclide perfusion scan every 6 months. Let's do a multi-slice CT after every 1 year. It's not recommended whether to do periodic anatomical, like a multi-slice CT or a coronary angiography, or ischemic functional testing, like a stress echo, a stress test, a stress MPI scan. If the patient does not have any change in the clinical or functional status, it's not recommended. If the patient develops something new symptoms, develops something impaired ejection fraction, developing dyspnea, developing chest pain, okay, you can go on with the risk stratification test. Otherwise, it's not recommended to routinely perform those tests if the patient is clinically and functionally doing fine. Finally, lots of questions go inside the clinic. What about the e-cigarettes? I want to stop smoking. I will stop smoking the regular cigarettes. I will go with the electronic cigarettes. I will go with the whatsoever. Actually, it could be used as a step in the smoking cessation, but it is not used as a replacement. And of course, we're not encouraging those who are non-smokers to use e-cigarettes because it looks like fashionable or so on. No, using e-cigarette is not recommended as a first-line therapy for smoking cessation. You may use it, but is not the first line. Sometimes you can use medication like varenicline and so on, bupropion, but not using e-cigarette. And of course, there is a special recommendation of harm, class 3, red sign with a harm label for patients with CCD who are exposed to secondhand smoke. Even secondhand smoke is harmful. Thank you so much. This was a wrap up of the ACC guidelines for the CCS, which was published in December 2023, and the comparison between that as well as what was going on in the European Society of Cardiology guidelines. And thank you so much.